This lecture focuses on labor and birth complications, and that is chapter 17. So in this chapter, we're going to discuss some of the things that can cause complications during the intrapartum period. So we'll find out some of those labor and birth complications during the course of this lecture. These are your student learning outcomes. Please take the time to review them as you go through this lecture. Let's take a look at the first complication, which is preterm labor and birth. Preterm labor and birth, I remember the very first time we met, we talked about term gestation, preterm, and postterm. And so preterm labor refers to cervical changes and uterine contractions which occur at 20 to 37 weeks of pregnancy. So it means that the woman did not make it to 38 weeks. And so the preterm birth will be birth that occurs before the completion of 37 weeks. And so with this preterm birth, there's a concern about low birth weight. So you have low birth weight that is associated with preterm birth. Preterm birth or prematurity has to do with the length of gestation regardless of the birth weight. This is more dangerous than birth weight alone because less time in the uterus correlates with immaturity of body systems. So the best place for the fetus to be in is in the uterus. So when the baby or when you deliver a baby prematurely, it's not really good for the baby because the baby is not fully matured. And so the low birth weight is any weight that is less than 2,500 grams at birth. So the normal fetal weight or the normal estimated fetal weight is usually from 2,500 to 4,000 grams. Any weight that is less than 2,500 grams is considered as a low birth weight. If it is more than 4,000, it is considered as larger for gestational age or weight. And so there are many potential causes that can cause or can lead to this low birth weight. So that includes preterm labor or preterm birth. And also there is something known as IUGR or intrauterine growth restriction. So an intrauterine growth restriction is usually the cause of low birth weight. So it means that the fetus growth was restricted in utero. And there are several things that could cause that to happen, such as maternal high blood pressure, if mom has gestational hypertension, chronic hypertension, preeclampsia, or superimposed preeclampsia, or she uses cocaine, abuses drugs. So those things can cause intrauterine growth restriction. So that could be the reason why you have a low birth weight. So always remember that there is, when you have a preterm birth, the most concern is about the low birth weight, and that is because of the prematurity of the fetus. According to statistics, preterm births occur in 11.55% of births here in the US, and this is according to the World Health Organization. Preterm labor is the leading cause of neonatal mortality in the United States. Preterm labor accounts for 75% of neonatal morbidity and mortality without birth defects. So there are also maternal or multiple maternal risk factors associated with spontaneous preterm labor. Here in the United States, African American women experience preterm births twice the rate of white women. So the question is why? Why that disparity? Well, some of the possible reasons include heredity. So there are hereditary conditions such as hypertension, diabetes, dietary choices, obesity, poor access to healthcare. I remember when we covered the 2020, the Healthy People 2020 goal, we said one of the goals is to ensure that there is access to early prenatal care for every woman. There are still some women who have poor access to health care, and that is one of the reasons why you see that increase in the amount of women who experience preterm birth among the African American population. There are also signs associated with preterm labor. So what are those signs of preterm labor? Well, these include abdominal pain, back pain, pelvic pain, vaginal bleeding, intermittent cramps or contractions, vaginal mucus discharge, pelvic pressure, urinary frequency, and diarrhea. So a patient who presents in it with any of these or some of these symptoms is in preterm labor and must be admitted. So now there are medications that we give to patients who present in preterm labor, and these medications are called tocolytic agents. So tocolysis refers to medications used to delay birth in order to give steroids. So steroids are given to moms who present in preterm labor in order to enhance the fetal lung maturity. So tocolysis are medications that we give to moms to delay the birth process in order for the steroids to be given and be effective. These medications include Ritadrine. However, Ritadrine is no longer used in preterm labor due to its side effects. Nifedipine, which is a calcium channel blocker, is used. So we use nifedipine. We can also use magnesium sulfate. I know this is the second time we're mentioning magnesium sulfate in this maternity lecture. The first time we talked about magnesium sulfate being used among a pre-eclamptic population in order to prevent seizures. So now with preterm labor, the use of magnesium sulfate is as a tocolytic agent. So we give magnesium sulfate to slow uterine contractions down. It serves as a tocolytic agent because magnesium is a smooth muscle relaxant. So it helps to slow the contractions down so that mom can receive the steroid for the fetal lung maturity. So magnesium sulfate is used. We also use a medication that is a beta mimetic known as tobutylene. So tobutylene is used as a tocolytic agent to slow or to delay birth. Indomethacin is another medication. However, indomethacin is not recommended after 34 weeks. So you have a patient who presents after 34 weeks, indomethacin is not a choice of tocolytic agent to offer this patient. And so with tobutylene, one point you want to remember with tobutylene is that tobutylene will cause palpitation. So after the patient receives tobutylene or before you give it to the patient, you have to explain to them that they may feel like their heart is racing. So that is an expected effect. So you'll have maternal tachycardia and they will have that palpitation. You may also have fetal tachycardia as a result of that tobutylene. Tobutylene is also used to space contractions out, especially if mom is contracting too frequently. Sometimes mom may be having more than 5 contractions. If she's having 5 or more contractions in 10 minutes, that is too much. It's called tachysystole. So when a woman is having 5 or more contractions within 10 minutes period, that is not right. That woman is contracting too much. So we give her tobutylene because of that tachysystole. So now let's take a look at spontaneous versus indicated preterm birth. The spontaneous preterm birth, these are preterm birth that happen spontaneously, and this accounts for 75% of preterm births. Now, there are about 25% of preterm births that are indicated. So this means that these women were actually induced for labor, even though they were preterm. And so this is only for medical reasons if their mom is severely sick and that we have to deliver as at preterm, or if there is a fetal indication. So it has to be an indication for that to happen. And that accounts for 25% of preterm births. The majority falls under spontaneous preterm birth. There are causes of spontaneous preterm labor and birth. These causes are multifactorial. So it's not only one thing. It's a group of things that could lead to preterm labor and birth. However, infection is the only definitive factor. So infection remains the only definitive factor which predisposes a woman to go on into preterm labor and birth. There are also some attribution to placental causes. So you have multifactorial infection and placental causes. So what are the risk factors? Well, the risk factors includes the first one there is cervical length. What is cervical length? Well, cervical length refers to the length of the lower end of the uterus. So when a woman is pregnant or during this pregnancy, the length of the cervix might shorten too soon. So if that happens, it increases the risk of preterm labor and premature birth. During pregnancy, the normal length of the cervix should be at least about 40 millimeters. In some women, it may vary. However, if there is a cervical length greater than 30 millimeters, it's an indication that that woman is unlikely to give birth prematurely. Once you have a cervical length that is less than that, less than 25 millimeters, it is an indication of a higher risk of preterm birth. So we look at the cervical length, although not predictive of preterm labor or birth, but it gives us an idea of the likelihood that this can happen. We also use what is called the fetal fibronectin test. And this fetal fibronectin test is a glycoprotein glue that is found in plasma and produced during fetal life. So once it is present, that is usually an indication that preterm labor and birth is likely. The care management of preterm labor, well, it begins with assessment. So you want to assess your patient. If they are in preterm labor, it's very important to provide patients teaching. Teach them about things to do and things not to do. There are certain interventions that need to be implemented. Prevention is one of the interventions. So prevention is important. We always encourage our patients to drink lots of fluid. They need to drink fluid because most times if they are dehydrated, they'll start having early contractions. So early recognition of this preterm labor is the key. You want to recognize it on time and have a prompt diagnosis for that. Once early preterm labor or preterm labor is diagnosed, there is a requirement for lifestyle modifications. So lifestyle modifications has to be done. Activity will be restricted. So you have activity restriction, a restriction of sexual activity. A home care is also important. So this is a patient who may benefit from the visit of a home care nurse or visiting nurse. And of course, we'll do suppression of uterine activity by the use of the tocolytic medications that we mentioned previously. Promotion of fetal lung maturity is very, very essential. And in order to promote the fetal lung maturity, we administer the steroid to the mom. So the patient who is in preterm labor gets the administration of the steroid. So these antenatal glucocorticoids helps to significantly reduce the incidence of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and death in neonates. This is why it is very, very essential to ensure that the mom who presents in preterm labor receives the steroid. These steroids have significantly, once again, reduced the incidence of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and death among our neonates. So early recognition is the key, and of course, you need to do all these interventions. The nursing care includes, once again, administration of the corticosteroid to the mom to prevent respiratory distress syndrome in infants. So the woman gets the steroid. The steroid we give is called beta-metasone. So she receives the beta-metasone, which is a steroid, and we usually give it times 2 doses. So it's given every 24 hours. So let's say the woman came in this morning at 10 o'clock and she receives the steroid at 10 or 10:30 in the morning. The next dose will be the following day at 10 o'clock. So she needs 2 doses of the steroid, and that will ensure the maturity of the fetal lungs. So that is very essential to administer that to the mom who is presenting in preterm labor. It is also important to administer antibiotics and tocolysis to this woman. You need to monitor for signs and symptoms of preterm labor and offer supportive care, offering emotional support to the patient. Health promotion education will include things like teaching childbearing women signs and symptoms of preterm labor, and also teaching them about the risky behaviors to avoid during pregnancy, such as smoking, the use of alcohol, and drug use. Early treatment of any bacterial infection is very essential. Remember, we said that one of the causative or the primary causative factor is infection. So once infection is detected during pregnancy, it is very essential to treat the bacterial infection. And management of an inevitable preterm birth includes a fetal and early neonatal loss. So if you have a woman who, I think we touched on this when we covered abortion, if you have a woman who had a loss at 20 weeks, that is that will be an abortion. Also, after 20 weeks, so if you have a woman who delivered at 21 weeks, 22 weeks, 30 weeks, well, that is a neonatal. You have a stillbirth. And so that stillbirth, you have to manage, you have to provide emotional support to the patient. If it's a neonatal loss, you also want to know how to manage the patient as she grieves for the loss of her baby. So these maternal steroids helps to reduce the incidences of respiratory distress syndrome in the premature babies. And also there are social difficulties associated with long-term hospitalization when mom delivers a preterm baby. So some of those social difficulties include loss of pay. So the woman may not be going to work. She will be out of work. Childcare, disruption of routines, depression, anxiety. And so these are some of the difficulties associated with long-term hospitalization, because when the baby is delivered prematurely, the baby will be in the NICU for a long period of time, depending on the age of delivery or how premature the baby was. So the mom, her social life will be kind of disrupted because of that. Now let's look at PROM and PPROM. What is the difference between PROM and PPROM? Well, PROM means the spontaneous rupture of amniotic sac and leakage of amniotic fluid prior to the onset of labor at any gestational age from 38 weeks. So PROM means premature rupture of membrane. So the woman broke her water prior to the onset of labor at 38 weeks and above. So this woman ruptured her membrane, but she is not feeling contractions yet. So that's what that PROM or premature rupture of membrane refers to. Now, PPROM is different. PPROM stands for preterm premature rupture of membrane. So this woman preterm ruptured her membrane before completing 37 weeks and starting labor. So that is a preterm premature rupture of membrane. Some of the causes of this PPROM or preterm premature rupture of membrane, there are multiple factors, but this PPROM is responsible for about 10% of all preterm births. It's often preceded by infection, and other causes include chorioamnionitis, and this chorioamnionitis is the infection of the chorion and the amnion. Cervicitis is also another risk factor or another cause. UTI, asymptomatic bacteriuria, amniocentesis, placental previa, abruptio placenta, hydrominus, leprosidius, multiples in pregnancies. These are causes for a preterm rupture of membrane or preterm births. 50% of women who PPROM at 28 weeks to 34 weeks usually will deliver within 7 days. So when you have a patient who PPROMs, what will be your nursing care? Well, this is usually determined according to or as per individual, so it's determined individually. You want to assist to confirm the rupture of membrane via the use of a sterile speculum exam. So the speculum exam is used to confirm that this woman actually ruptured her membrane. And then you need to provide patient education. Once after rupture of membrane, the patient needs to avoid vaginal exam. You need to avoid vaginal exams on the patient, and this is because of the risk of infection. The temperature of the patient needs to be monitored. So you want to monitor the temperature, the pulse, the fetal heart rate. Those are very, very important to be monitored, because if the patient broke her water, the risk of infection becomes higher. So your diagnosis for a woman who breaks their water would be what? Risk for infection, because they have ruptured the amniotic sac. And the maternal and neonatal risk. Let's look at the maternal risk first with rupture of membrane. The maternal risk include chorioamnionitis, and the chorioamnionitis means or refers to bacterial invasion and inflammation of the membranes. So the chorion and the amnion are now infected, and that is a maternal risk. Chorioamnionitis occurs in 3% to 15% with premature rupture of membrane. Chorioamnionitis also occurs in about 13% to 60% with preterm premature rupture of membrane. Dysfunctional labor pattern is also another maternal risk, and when that happens, there is a need for cesarean section. So the need for C-section increases with dysfunctional labor pattern secondary to rupture of membrane. Endometritis is another risk factor. The endometritis means infection of endometrium during the postpartum period. So this endometritis happens during the postpartum period. Endometritis is not the same as endometriosis. Remember, we covered endometriosis when we talked about some of the women's health problem. That is different. This is endometritis. This is infection of endometrium during the postpartum period. Your nursing care includes checking maternal temperature, the maternal heart rate, respiratory rate, but particularly the temperature is very, very important to check the heart rate. Assist with vaginal cultures, antibiotic therapy, administration of acetaminophen, doing an NST for fetal status. So you want to do that non-stress test to see how the fetus is doing. Comfort measures for patients with non-viable fetus. So if you have somebody whose fetus is non-viable, you want to offer emotional support to them as well as education. Some of the neonatal risk associated with rupture of membrane includes fetal tachycardia, pneumonia, and sepsis. And these can result in complications, and some of the complications are complications of respiratory distress syndrome, neonatal infections, or sepsis, and this is seen in about 2 to 4% of babies. There is also another complication known as necrotizing enterocolitis, intraventricular hemorrhage. There is increased morbidity and mortality with prematurity, and hence the administration of that beta-metazone for lung maturity. Treatment includes the use of antibiotic therapy and lab work to rule out sepsis. Now let's shift our attention to postterm pregnancy, labor, and birth. And postterm pregnancy refers to any pregnancy that is greater than 42 weeks of gestation. And so with these postterm pregnancies, there are maternal risk and fetal risk involved. Let's take a look at the maternal risk first. Maternal risks that are often related to dysfunctional labor is seen in postterm pregnancy. So you have dysfunctional labor and birth canal trauma, and it puts the woman at increased risk for perineal injury related to fetal macrosomia. There are also risks for hemorrhage and infection. Interventions such as induction, with prostaglandin or oxytocin, or the use of forceps or vacuum-assisted birth and cesarean birth are more likely to be necessary. So they start, intervening because you have a baby that is more than 42 weeks. The patient may experience fatigue and psychologic reactions as estimated date of birth passes, and that is normal. So this woman may have that physical discomfort. She may become even depressed, frustrated, and starts to feel inadequate as she passes her estimated date of birth. This also affects relationships with families and friends. So relationships with close friends and family members may become strained, and a woman's negative feelings about herself may be projected as feelings of resentment toward the fetus. So these are some of the associated maternal risk with postpartum pregnancy. What about the fetal risk? Well, with fetal risk, we have abnormal fetal growth. So abnormal fetal risk is a complication associated with postpartum pregnancy. Although the risk of having a small for gestational age infant is also increased, but that is only noted in 10% to 20% of postpartum fetuses. Macrosomia is more likely to happen in postpartum pregnancy than small for gestational age. Macrosomia occurs when the placenta continues to provide adequate nutrients to support fetal growth after 40 weeks of gestation. These macrosomic infants also have an increased risk for operative delivery and shoulder dystocia, leading to fetal injury. So other fetal risks associated with postpartum gestation are related to intrauterine environment. Around 42 weeks, the placenta begins to age. So you have compromising effects of fetus of aging placenta, enlarging areas of infection and increase the position of calcium and fibrin in its tissue, decrease the placenta's reserve, and may affect its ability to oxygenate the fetus. A decreased amniotic fluid is also seen in postpartum pregnancy. And so we have what is called post-maturity syndrome. And that post-maturity syndrome occurs in about 10 to 20% of neonates who were born following postpartum pregnancy. It is characterized by dry, cracked, peeling skin. So if you see a baby that is delivered at 42 weeks and more than 42, you will see that dry skin. They have the peeling skin, cracked skin, long nails, meconium staining of skin, nails and umbilical cord, and perhaps loss of subcutaneous fat and muscle mass. Dysfunctional labor, dystocia. So dystocia is another dysfunctional labor or another complication that we might see in labor. And so let's look at some of the causes of dystocia. And the first one there is abnormal uterine activity. So you could have an abnormal uterine activity, and that could happen there are two categories. It could be a hypertonic uterine dysfunction. And if there is a hypertonic uterine dysfunction, so it means that the woman is contracting too much. And so usually we'll put them on therapeutic rest. We want to rest them to stop that contractions or give them tocolytic agent. Hypotonic uterine dysfunction is another abnormal uterine activity. And this usually initially makes normal progress into the active phase of first stage of labor, but then the contractions become weak and inefficient, or it stops altogether. So with hypotonic uterine dysfunction, usually I will give oxytocin to continue to enhance or to augment the labor. And once it's not working, well, the woman may end up having a C-section. Another problem or another cause of this dysfunctional labor could be with the secondary powers. I remember we said that the primary power of labor is contraction, but if the secondary power, which is that urge to bear down, is not there, so if the woman has problems with bearing down efforts, that becomes a problem. If the woman is not able to bear down and push effectively, that is a dysfunctional, that could lead to dysfunctional labor, and it also increases the risk of having a C-section. Abnormal patterns or labor patterns is also another dysfunctional labor cause. According to we have what is called the Friedman's classification of normal labor patterns. And so usually the doctors will follow the labor curve to see if the woman is in a good, adequate labor pattern. So if she falls off that curve, then chances of C-section increases. Precipitous labor is also another dysfunctional labor. With this precipitous labor, this is labor that lasts less than 3 hours from the onset of contractions to the time of birth. So you have a patient who presented and the doctor checked the patient. The patient was about 3 centimeters and she's contracting away. The doctor says, you know what, instead of sending you home, let's just recheck you in 2 hours. And in less than 3 hours, the woman just, boom, delivers the baby. And the baby just flew out like the house was on fire. So that is a precipitous delivery or labor that lasts less than 3 hours from the onset of contraction to the time of birth. Alterations in pelvic structure could be also another cause of dysfunctional labor, and this leads to what is called a pelvic dystocia. So pelvic dystocia, in pelvic dystocia, you have contractures of pelvic diameters that reduce the capacity of the bony pelvis, the inlet, mid-pelvis, or the outlet. So if there is a difficulty with the pelvis, that could definitely lead to dysfunctional labor. It can also be in the setting of a soft tissue dystocia, which usually results from obstruction to the birth passage by an anatomic abnormality other than that of the bony pelvis. Position of the woman is also another cause of dysfunctional labor. Remember earlier in the previous PowerPoint, we talked about the position as one of the factors affecting labor. So if the woman, if maternal position alters relationship between uterine contractions of fetus and mother's pelvis, then that becomes an issue. So you want to make sure that the woman is placed in a proper position so that it doesn't affect the labor. Psychologic responses is also another cause of dysfunctional labor. And this has to do with the hormones and neurotransmitters that are released in response to stress. So those hormones and neurotransmitters, they can actually cause dystocia. Sources of stress and anxiety vary according to individuals. So these are some of the things that could cause dysfunctional labor. Prolactin, actually, I wanted to say something with regards to these the hormones. So oxytocin is one of the hormones that is produced by the posterior pituitary gland, and this oxytocin helps with that uterine contraction. So if you don't have enough oxytocin, well, that could lead to that dystocia because you have that difficulty. So if there is no oxytocin, then you won't have that uterine contractions, and we will have to give that woman a little bit of the exogenous oxytocin so that she could, get the contractions pattern going. So yes, hormones and neurotransmitters can cause dystocia or dysfunctional labor. Now let's consider some of the fetal causes for dysfunctional labor. And some of the fetal causes include fetal anomalies, cephalopelvic disproportion, CPD, also called fetal pelvic disproportion. And so with this cephalopelvic disproportion, this usually leads to having a C-section. And so this CPD is just a big old word to say your head is too big for your mom's pelvis. So if the head, the cephal is the head, if it's not getting or descending into the pelvis, if it's not getting down there, there's no way the baby will be delivered vaginally. So in a case of a CPD or FPD, the baby will be delivered via a C-section, and moms usually will deliver via a classical incision. And so they will have a classical incision because the head is still up high in the setting of a CPD. Malposition is another fetal cause of dysfunctional labor. I remember we covered the malpresentation, the bridge, frank bridge, complete bridge. definitely causes of dysfunctional labor. A multi-fetal pregnancy is also associated with more complications. I'm going to now discuss some obstetric procedures. And the first one is the version. There are two types of version. We have externocephalic version and we have the internal version or podalic version. And so this version is an attempt to turn the fetus from a bridge or shoulder presentation into a vertex presentation for birth. So if a patient has to undergo version, there are certain criteria that needs to be met. So in order for your patient to be a candidate for a version, she has to be a singleton mom. So she has to be carrying one pregnancy. The fetus will be in a bridge presentation. So you have bridge not engaged. You must have a reactive non-stress test. Version is done between 36 to 37 weeks gestation. There are higher success rates with multiparity, adequate fluid, lack of fetal engagement, transverse slide, palpable fetal head, and a relaxed uterus. Ultrasound scanning is used or is done during the procedure. So this is a procedure that is done under the guidance of ultrasound. You have to know where the fetal position is, the placement of cord, and adequacy of pelvis. So the ultrasound helps to find out all this information. NST or non-stress test is done, and you need to have an informed consent before the procedure. So informed consent must be received because this woman who is going for reversion needs to be consented to. You have to explain to her the benefits, the risk, the alternatives. You have to tell her everything about the procedure. It may work or it may not work. So if it doesn't work, she gets a C-section. So she needs an informed consent for that. And of course, it mentioned that her uterus needs to be relaxed. So in order to relax the uterus for this procedure, we use terbutaline. So terbutaline, remember we talked about terbutaline as a tocolytic agent. We gave terbutaline to relax the uterus prior to aversion. So by now you should know that medications are dual functional. So one medication could be used for different purposes. So terbutaline is used to relax the uterus prior to aversion. So we give it to mom, and remember also if you're giving a patient terbutaline, you need to tell them that it could cause palpitation. They could feel that their heart is racing. Now there are contraindications associated with version. The contraindications include oligo, and oligo means you don't have too much fluid around the baby. So once the fluid is less than 5 centimeters, you will not be a candidate for that. So that's what oligo is. I remember in the previous on the slide it mentions that there is higher success rate with adequate fluid. So that means that if you don't have adequate fluid, you're not a candidate. So it's contraindicated in oligo, nuchal cord. So it makes sense that if there is cord around your baby, the baby's neck, you don't want anybody to turn the baby if the cord is there, unless they want to kill the baby, and that's not right. So nuchal cord is definitely a contraindication, and that's why you need to use the ultrasound to look at the baby. Other abnormalities, when you have babies with congenital abnormalities, please don't vert them. Internal version or podalic version is rarely used because there is a safety question about that. However, most times if it's used in twin gestations. So if you had mom who is pregnant, so little Jasmine came out vaginally, and Matthew decided to go bridge. So the doctor goes in and say, hey, little Matthew, you're coming out. And then try to go in and internally rotate the head of Matthew so that Matthew could be delivered vaginally. Sometimes Matthew may say, you know what, leave me alone. Get the hell away from me. I want to have a C-section. I'm not coming down. Or maybe something is holding me up here. And we've actually had instances where mom delivered one baby vaginally and then the other baby is delivered via C-section. So these are the two types of version. So this is a picture of that version. So A is a picture of that. So you see the baby is in that. This is a butt of Frank Bridge, say the bud is presenting. So that is Frank Bridge, and the doctor is trying to rotate the fetal head. So you see how follow the arrow, you see that the doctor is externally trying to rotate the head of this fetus into a cephalic position. So there's a success. You see that the head was finally rotated as the presenting part. So it's no longer the buttocks, it is now the head that is presenting. So this is a picture of a successful version. Once it is successful, the woman may go into labor on her own, or we may start her induction of labor. Induction of labor. Induction of labor is another obstetric procedure, and this is done to initiate uterine contraction. So induction is the chemical or mechanical initiation of uterine contractions before the spontaneous onset for the purpose of bringing about birth. So this woman who is being induced, we're making her body to do something that is not really ready to do. So that is why it's called an induction of labor. A labor may be induced either electively or for indicated medical reasons. And there's a lot of reasons why a woman could have her labor induced. A woman's induction could be induced for things like passing her due date. So a woman who passed her due date may have a scheduled induction of labor for post-term or late term. And you can also have an induction of labor for a history of IUFD. So if a woman had an intrauterine fetal demise with her previous pregnancy, let's say the woman had that incident around 39 weeks or 40 weeks. You know what will happen if she's pregnant again? As she gets closer to that period, this woman will have a freaking PTSD. She'll start having flashbacks. So normally the doctors will say, you know what? Once she hits 38 weeks, we're going to induce her labor. So there are reasons for induction of labor. It can also be induction of labor secondary to preeclampsia, gestational hypertension, gestational diabetes, cholestasis of pregnancy. So there are several reasons why an induction could take place. But whatever the reason is, it's always advisable to wait at least until the woman makes it to 38, 39 weeks, unless there are many pressing reasons why she will not wait that far. Elective induction of labor is when a labor is initiated without a medical indication. So I just listed some of the things that could be medically indicated for induction. But electively, a woman could have an induction started, and this is without a medical indication. Many are for the convenience of the woman or our primary health care provider. However, there are risks associated with elective induction of labor. There is increased rates of cesarean birth, increased neonatal morbidity, and increased cost. You know how much each night you spend in the hospital? How much it costs? The most expensive bed in the whole world is the hospital bed. It's very expensive. So each day the woman is there for her labor to be induced is an increased cost. An induction could last anywhere up to 3 days. Imagine if you had come in. We love those ones. They come in and deliver. We call them drive-by. Like you go into McDonald's or Wendy's and you drive by, you come in, you drop your baby and you're gone. The cost is reduced. But if you're coming in for elective induction and you have to stay there for a longer period of time, yes, there is risk for increased cost. Elective induction of labor should also not be initiated until the woman reaches 39 weeks. So this has no medical indication. So you have to wait till 39 weeks. And we have the Bishop score. This Bishop score is a rating system used to evaluate inducibility or cervical ripeness. And so the Bishop score takes into consideration the cervical dilation, the station, the effacement, the cervical consistency, and position. So it kind of gives you a score to see if in the woman, the inducibility or cervical ripeness is increased or not. So this is what the Bishop score will look like if you look at this image. So they look at each of these things gets a score. The dilation, is she closed? Is she 1 to 2, 3 to 4, and the rest, just like that. And so you have to, if you have a Bishop score of at least 7, that's a good thing. A Bishop score of 6, that shows that the chances of the woman being successful with her induction, that is increased. Now, in order to induce a woman, we have cervical ripening methods. And these cervical ripening methods, these are things we do in order to ripen the woman's cervix. So we use chemical agents. So chemical agents can be used, such as misoprostol. Misoprostol is a cervical ripener. We use it as a little pill. We'll put it inside the woman's cervix, leave it there. Every 4 hours, the woman gets checked. So that is a cervical ripener to ripen the cervix, to make it ripe. Because induction, it cannot be started if the cervix is not ripened. So we do that. We also can use what is called a dinoprostone or dinoprostone. That is like a mesh that the doctors will place into the cervix and allow it to stay in place for 12 hours. If we don't use those, we could do mechanical and physical method using what is called the cervical Foley. So the cervical Foley, just like the Foley catheter goes into the urethra, this cervical Foley goes into the cervix. The doctor will thread it into the cervix, and once it gets in there, it will be inflated with about 50 to 60 cc's of normal saline, and then they will tape it on the woman's thigh so that it kind of puts traction. So the essence of doing that is to mechanically soften and open the cervix. So it's like a traction, it pulls the cervix to mechanically open it. And so once the Foley balloon comes out, it's assumed that that woman should be at least about 3 to 4 centimeters open. There are alternative methods that we use, such as the stripping of the membrane. So the doctor goes in and examines the woman and try to strip her membrane, and that can be painful. So that's an alternative way of starting the induction. Amniotomy is also another way, and that is the rupture of membrane. So if a woman is not ruptured on her own, the doctors or the midwife, if they broke her water bag, that is called amniotomy, and that would be considered as artificial rupture of membrane. And that is a way to, cause the progression of the labor. Oxytocin is also another agent that we use in induction of labor. And oxytocin is a hormone that is produced by the pituitary gland. So that oxytocin is responsible for triggering uterine contraction. It also is responsible for enhancement of milk ejection or the let-down reflex. But in labor, oxytocin is used to stimulate uterine contraction. And so we give the patient a little dose of oxytocin, we start them on that, and that helps to cause contractions to take place. Every woman makes oxytocin, and the oxytocin that we make is known as the endogenous oxytocin. However, in augmentation or induction of labor, we will get the synthetic version or the synthetic pitocin or oxytocin, and this may be used either to induce labor or to augment labor that is progressing slowly because of inadequate uterine contraction. So that is what happens with the induction of labor. Oxytocin is a medication that we have to give in using the IV pump, and it's titrated very slowly. It's a very powerful medication, so we titrate it very, very slowly, and we have to watch the contraction pattern. So if your patient is on oxytocin and they are having tachysystole, which is 5 or more contractions in 10 minutes, you need to stop the oxytocin because the woman is contracting too much, and that could cause fetal decelerations to happen. This is a picture of a doctor who's about to perform amniotomy So this instrument here, or this device here, is called the amnio hook. So this is what the doctor will use to perform amniotomy, and that is the stimulation of uterine contractions after labor has started spontaneously and progress is unsatisfactory. So the doctor will go in, or the midwife will do the amniotomy, the rupture of membrane. So once the doctor or the midwife ruptures the membrane, it is known as artificial rupture of membrane. So the woman's membrane is ruptured, and that helps to progress the labor, or to get things moving a little faster. So after that, common augmentation method will include oxytocin infusion. So oxytocin infusion and amniotomy helps with the progression of labor. And once your patient's membrane is ruptured, you need to manage them actively, because remember, with amniotomy, the risk of infection increases, because once you rupture the membrane, now the woman can get infected. So you need to actively manage them so that they could deliver on time. Other procedures include operative vaginal birth. Now, operative vaginal births are performed using either forceps or a vacuum extractor. In this picture, you see the doctor applying the forceps on the baby's head. And this is known as a forceps assisted birth. For a patient to have a forceps assisted birth, certain criteria needs to be met. The forceps are applied when fetal skull has reached the pelvic floor and is at or on the perineum. So you have to, the head has to be vacuumable for that to take place. So for you to apply the forceps, you have to have the fetal skull at the pelvic floor or at the perineum. There are different types of forceps. We have the you have outlets, a low forceps, mid forceps, high forceps, and this high forceps is not acceptable. There is a need for cesarean section or cesarean delivery. Now, there are risks associated with forceps-assisted birth. A forceps fails, a failed forceps and a failed vacuum needs cesarean section. So if it fails, if the woman is not, if the fetus or the baby is not able to be delivered via this operative vaginal birth, then you have to have a C-section. So risk include failed forceps and vacuum, and there will be a need for a C-section. This is a vacuum-assisted birth, which is another operative vaginal birth. So in this case, the doctors are applying a vacuum on the crown of the fetal head. So this is what the vacuum will do to the head of the fetus or the baby when the baby is delivered. So that vacuum is like a round, it makes a round impression. It's right like a cup. So they apply it to the crown of the fetal head and apply traction to it. So it usually with mom's coordinated pushing efforts, the doctor would try to pull the baby out. So there are contraindications with the use of vacuum. Vacuum is not to be used in non-vertex presentation. Well, that makes sense. If the head is not there, where will you apply the vacuum? You can apply it on the butt or the leg. So it has to be on the head. Less than 34 weeks, non-vacuumable. You cannot vacuum a fetus that is less than 34 weeks before you pull somebody's head out. Macrosomia, definitely a no-no. So these are contraindications. Hydrocephalus, high fetal station, not fully dilated, please do not vacuum. They need a C-section. So these are your contraindications. And that is what the picture, this is what the baby's head will look like after a vacuum. So you'll see that this baby has what is called a cephal hematoma. And we're going to talk about this when we go to newborn. And so this is cephal hematoma, secondary to the vacuum that is applied on the baby's head. Cesarean birth. A cesarean birth is a birth of an infant through an abdominal and uterine incision. It accounts for 1 in 3 births in the United States. Not every woman delivers via C-section, but there are some indications why a woman could end up in a C-section. And those indications include complete placental previa, placental abruption, cephalopelvic disproportion, as I mentioned earlier, failure to progress, failure to dilate, a woman who has active genital herpes, so HSV active lesion, a woman who has a prodromal HSV, prolapse cord, which is an obstetrical emergency, non-reassuring fetal heart rate status, bridge or transverse lie. These are indications for a C-section. And also, if a woman had a prior C-section, she could also have an elective repeat C-section. Sometimes too, if you have a fetal anomaly, that will be an indication for a C-section. For instance, if you have a fetal anomaly known as fetal gastrochesis, where the abdominal contents, the intestine, are all out, or that woman will have to go for a C-section. And this is a baby that will go for immediate surgery immediately after birth. So those kind of major fetal anomalies or even cardiac anomalies will require a C-section. If a woman has fibroids that are obstructing the passageway, that will also be a reason for a C-section. There's a lot of other reasons. You have mom who has a severe cardiac disorder. That woman will have a C-section as well. If you've had a prior myomectomy, so myomectomy is the surgical removal of fibroid, that would be a reason for a C-section. A woman with an invasive cervical cancer will have a C-section. And so there are other reasons. A woman who has an HIV with high viral load, that is also a reason for a C-section. That is because of the viral load, not because of the HIV, but because her viral load is high. That is a reason for a C-section. So with C-section, you can have a low transverse uterine incision. And this is the traditional way of having a C-section. The woman gets a low transverse incision. If you look at this image here, you see the low transverse incision. Another name for this low transverse incision is the phalansteal. So it's called phalansteal. The P is silent. So phalansteal incision, or you can also call it the bikini cut. So we call it bikini. And the reason why we call it bikini is that this woman can still wear her bikini and no one will know that she had a C-section. So bikini, low transverse, phalansteal, they're all the same thing. It's done around the suprapubic area. And this incision is made on the isthmus of the uterus. The isthmus is the thinmost portion of the uterus, and that is where the doctors will make that incision for a low transverse incision. Another uterine incision is called classical. And so this is a classical. Classical is only reserved for emergencies. A woman who is having any obstetrical emergency will do a classical C-section. Also with moms who are carrying a CPD baby, cephalopelvic disproportion, she'll have a classical C-section. Now, key things to remember is that if a woman had a classical incision, that woman who had a classical incision will never be a candidate to have a vaginal birth after cesarean delivery. And this is because of the risk of uterine rupture is higher in moms who have a classical incision than moms with a low transverse incision. The uterus is repaired in layers. So in a C-section, they go through the skin, they go through the fascia, the muscles, and then they get to the uterus. So it has to be repaired in layers after the C-section, after the delivery of the baby, and they have to put the layers back in order. A C-section has complications and risk. And so it's very important to provide patient teaching about the pre-op and post-op to prevent these complications. So some complications associated with a C-section include hemorrhage. You also have risk for infection, and some of the complications such as atelectasis, pneumonia. So those are, remember, C-section is a major surgery. You also have, it has to be done with the use of anesthesia, with the voiceover on pain management. If you listen to the voiceover, we covered the different pain management options that we have in OB. So for C-sections, we use a spinal anesthesia, epidural anesthesia. Under emergencies, we'll use a general anesthesia for moms who have obstetrical emergencies, moms who have severe scoliosis, thrombocytopenia, or if you have Harrington rod in place. So there are some risks associated with that too. With general anesthesia, you have the risk of respiratory depression on the fetus or the baby. So for C-sections, you want to prepare the moms prenatally, offering them educations, for what will happen, about what will happen during the pre-op period and the post-op. Moms need to be NPO before the C-section, so they don't eat from midnight. They have to come in, and usually we'll give them, we'll start IV fluid, labs are done, we'll send blood type, CBC, to, make sure that there is blood available, unless you have a mom who is refusing blood transfusion. So these are some of the things that need to be done during the pre-op period. And we usually give them a sodium citric acid known as Bicitra, and that helps to neutralize the stomach acid to prevent pneumonitis during the C-section. Your immediate post-op care, once they come out of the OR, and you want to make sure that you monitor their vital signs every 15 minutes. They need to be hooked up to the cardiac monitor. You also have to make sure that mom has a compression sequential device system on, or you put the TET stockings on her, because remember, the first day of the delivery, C-section, the mom is going to be resting, so we want to rest her and manage her pain. There's also risk for blood clots, so in order to prevent DVT, you have to use the sequential compression devices or the TET stockings, and at some point they will get the lower molecular weight heparin or Lovenox to help them. And it's also important to give them the incentive spirometer. The incentive spirometer helps with the re-expansion of the lungs post-operatively. So these are very important. And the next day, day one, they need to get up and walk. Early ambulation is the key. You need to get them up so that they can walk. So look at that picture, isn't that cute? Look at, this is in the OR. The daddy, the mom, and the baby. Such a beautiful sight. Vaginal birth after cesarean birth. A VBAC or TOLAC refers to vaginal birth after cesarean or trial of labor after cesarean. So a woman can be a candidate for a VBAC. However, for her to vaginally deliver depends on the type of incision that was used during the previous delivery. If this woman had a classical incision, she should not be able to VBAC. But if she had a low transverse, yes, she can do a vaginal birth. So this vaginal birth after cesarean birth is non-reoccurring indications of first C-section. VBAC is a viable, safe alternative to repeat cesarean. However, it has to be after one previous cesarean delivery. If you've had a second C-section, you forget the chances of VBAC, because the more C-section you have, the risk of uterine rupture increases. Low transverse uterine scar, an adequate pelvis, you have to have an OR available. Physician and anesthesia need to be available throughout the active labor, so that if anything, if there is any issue, she gets a C-section. There are complications associated with VBAC, and that include uterine rupture or dehiscence. And you know what dehiscence means, right? Dehiscence is when the wound now starts to separate. If it separates, you have to call the doctor right away so that they could put it back. And this is usually a concern when you have a mom who is obese. That is why obesity, we try to avoid that during pregnancy by following those recommended weight gain. So that uterine rupture or dehiscence can lead to hysterectomy, and hysterectomy is the surgical removal of the uterus. Blood transfusion is also another complication. Uterine infection, maternal or fetal death is a complication. Hypoxic ischemic encephalopathy is also another complication associated with vaginal birth after cesarean. Obstetric emergencies. Obstetric emergencies include things like meconium-stained amniotic fluid. This meconium-stained amniotic fluid is an indication that the fetus has passed stool prior to birth. It's usually a sign of distress. So you will see dark green colored amniotic fluid, or sometimes it's yellowish. There are possible causes of this meconium-stained amniotic fluid. Some possible causes include breech presentation. It can also be a normal physiologic function of maturity, and you have babies who are post-term, so you may see that. Hypoxia-induced peristalsis can also be as a result of umbilical cord compression. So that if a woman ruptures and she has meconium-stained amniotic fluid, you need to keep an eye on this woman. If she delivers, during the delivery, you will have the pediatricians at the delivery. So we usually call the NICU team. They will be there. Once the baby comes out, if the baby is vigorous, we're good. If the baby is non-vigorous, they have to suction those fluid out of the baby's lungs to prevent what is called meconium aspiration. Let's consider another obstetric emergency known as shoulder dystocia. This shoulder dystocia is really an obstetric emergency that can lead to lasting injury to the baby. Shoulder dystocia is usually unpredictable, but there are risk factors that make it more likely, especially having had a previous baby with a shoulder dystocia and maternal diabetes. So what is happening in a shoulder dystocia? Well, in the setting of a shoulder dystocia, the head is delivered, so head is born, but the anterior shoulder cannot pass under pubic arch. So the baby's anterior shoulder gets stuck behind mom's pubic arch. The newborn is more likely to experience birth injuries related to asphyxia, brachial plexus damage, and fracture. And mom is also at risk for having excessive blood loss from uterine atony or rupture, lacerations, extension of episiotomy, or endometritis. So in the setting of a shoulder dystocia, some interventions or maneuvers need to be implemented in order to safely deliver this baby. The first line of maneuver is known as the Mick-Roberts maneuver. Looking at this image here, you see this woman in a Mick-Roberts position. So this Mick-Roberts maneuver simply is hyperflexing maternal hips and telling the patient to stop pushing. So you want to hyperflex the maternal hips, and that is a knee to chest position. So you see how her knees are almost going towards her chest. So the reason to put her in this position is to widen the pelvic outlet by flattening the sacrum and increasing the lumbosacral angle. And so this, most times in about 90%, will lead to a success. And so along with this Mick-Roberts, we also do what is called suprapubic pressure. The suprapubic pressure is applied in either a sustained or rocking fashion to apply pressure behind the anterior shoulder in order to disimpact it from underneath the maternal symphysis. So those are two interventions that we do initially. So if those two interventions, the suprapubic pressure and Mick-Roberts, are not able to help to deliver this baby, the doctors will move to another maneuver, and that is to deliver the posterior arm. So the posterior arm is attempted to deliver. So the doctor will try to go in and deliver the posterior arm because it's the anterior shoulder that is stuck. Once the posterior arm is delivered, well, it will cause the anterior shoulder to be dislodged so that the baby can come out. And so in a bid to deliver the posterior arm, the doctors may sometimes purposely fracture the posterior arm or the shoulder. They may dislocate it in order to deliver the baby. Another maneuver is called the corkscrew maneuver. The corkscrew maneuver is usually done, and this is when the doctors apply pressure simultaneously in front of one shoulder and behind the other in order to move the baby about 180 degrees or into an oblique position. So it's trying to like using a corkscrew, like trying to rotate the baby. So that's trying to relieve that shoulder that is stuck. If that doesn't help, the doctor may do what is called the Gaskin maneuvers. And the Gaskin maneuvers is like pretty much placing the woman in all four positions. So she's in all fours, and to see if that will help. The doctor will do an episiotomy. So episiotomy is done in order to widen the pelvic outlet. So along with maneuver, the episiotomy and the Gaskin maneuver, putting the patient onto all fours, so this may help to deliver the baby. So now, if all these maneuvers fail, the McRoberts, the suprapubic pressure, the corkscrew maneuver, delivering the posterior arm, the episiotomy, which is cutting the perineum, making a cut on the perineum to widen the pelvic outlet. If all those things fail, the last resort is to do what is called Zavanelli. Zavanelli is pretty much cephalic replacement. So the doctor is invariably returning the fetal head to the pelvis for delivery via a stat C-section. The Zavanelli or cephalic replacement is the last resort, and that can be quite traumatizing. In fact, I've seen it twice in my experience as an L&D nurse, and that is so frequently traumatizing. Imagine the head that is out and the doctor is now replacing it, putting it back in, rushing to the OR to deliver this woman. So those are the maneuvers. Now there is one maneuver that is contraindicated in the setting of a shoulder dystocia. Fundal pressure is never used in shoulder dystocia. You never apply fundal pressure in the setting of a shoulder dystocia, because applying the fundal pressure will cause more damage to the baby. So the shoulder that is already stuck, if you are putting pressure on the fundus, you're pushing it further in and causing more damage. So that is a contraindication or a contraindicated maneuver. You don't use fundal pressure in shoulder dystocia. Cord prolapse. Cord prolapse is also another obstetric emergency. With cord prolapse, what is happening is that the cord lies beside or just ahead of the fetal head. And so when that happens, you have an interruption to the oxygen pathway. And so the cord washes or drops down in front of the presenting part. That is an obstetrical emergency. If you witness a cord prolapse, please call for help. Call for help because you're looking at an obstetrical emergency, and that will be something that will warrant an immediate C-section. You need to put the woman in a knee chest position, or you attempt pushing up, putting pressure at the perineum. So putting the woman in a knee chest position, applying upward digital pressure at the perineum is also important, or you can put her in a Trendelenburg position. So putting her in a Trendelenburg position is also another intervention. And of course, you should be on your way to the OR to deliver this woman, because that is occluding fetal blood flow. You have a few minutes to deliver this baby. In about 4 or 5 minutes, if you don't deliver this baby, you will have a dead baby. So with prolapse cord, once again, it occurs when cord lies below the presenting part of the fetus, and some of the contributing factors include long cord. So if a baby has longer cord, a cord that is longer than 100 centimeter, or if there is a malpresentation, as in breech, transverse lie, unengaged presenting part, that will cause that cord prolapse. And you see how the cord slips ahead of the fetal head in this picture, picture C. and that is an obstetrical emergency. And also it occludes the blood flow, the blood flow to the fetus, and that is not a good thing. You need to deliver this woman via an emergency C-section. Uterine rupture is an obstetrical emergency. This uterine rupture is a non-surgical disruption of the uterine cavity. It happens in about 1 in 2,000 births. With uterine rupture, there is complete rupture. There may be complete rupture or partial rupture. In a complete rupture, you have the endometrium, the myometrium, and serosa being separated. So the endometrium, myometrium, and serosa will be separated in a complete rupture. In a partial uterine rupture, one or more but not layers are disrupted. So you'll have what is called a window. This uterine rupture is associated with previous abdominal surgery, abdominal trauma, short interval between births, postpartum fever with prior cesarean delivery, one-layer closure on uterus, congenital uterine anomaly. So these are risk factors to having that uterine rupture. And this is the reason why if a woman had a classical C-section, she's not allowed to VBAC because the risk of uterine rupture is higher than the low transverse incision. So what will you see if your patient is experiencing uterine rupture? Well, the symptoms include fetal bradycardia, abdominal pain, uterine tenderness, hematuria, cesations of contractions. So the woman who is contracting and huffing and puffing, all of a sudden the contraction ceases and the woman goes into shock. So you will see signs of shock. The woman gets, diaphoretic, and the color will definitely start to change because she's bleeding internally. Rupture of the uterus can happen during labor and birth, and that could be due to intense spontaneous uterine contractions. It can also be due to labor stimulation, and that is why if your patient is on oxytocin, you have to monitor them. The use of prostaglandin is also, we have to be cautious on the use of those. Over-distended uterus can cause the rupture of the uterus, especially when mom is carrying multi-fetal gestation. Malpresentation is also a cause of rupture of the uterus. Difficult forceps-assisted birth, and it occurs more in multigravidas than in primigravidas. Anaphylactoid syndrome is another obstetrical emergency. This AFE, or amniotic fluid embolism, this is defined as a bolus of amniotic fluid, fetal cells, or other debris entering into maternal circulation, obstructing pulmonary vessel, thereby causing respiratory distress and circulatory collapse. And this is usually deadly. When AFE happens, when fluid embolism happens, amniotic fluid embolism, usually it is very, very devastating because it is the second leading cause of maternal death. A cause is unknown, but usually about 60 to 80% mortality rate. It occurs 1 in 8,000 to 1 in 30,000 pregnancies. The bad thing about this is whenever it occurs, you always have a maternal death. So you can have the diagnosis of amniotic fluid embolism until autopsy. So autopsy is what shows that a woman actually died from AFE. So that fluid, you have amniotic fluid, the bolus of it leaves that and it goes into maternal circulation, and that obstructs pulmonary vessels, causing respiratory and circulatory collapse. So that is very, very fatal. Symptoms of AFE include shortness of breath, hypoxia, cyanosis, cardiovascular, and respiratory collapse. So if it's recognized, you try to stabilize the mom. If you're able to save the woman's life doing CPR, but like I said, most times it is too late, and the patient will be delivered via emergency cesarean delivery. About a decade ago, we had to deliver a woman we had to do what is called a postmortem C-section. So postmortem means that the woman already died. So we had to deliver her via C-section immediately because she died from amniotic fluid embolism. Unfortunately, the baby survived. So if that happens, you want to try to save the baby at least. A pregnant woman arrives on the labor and delivery unit and informs the nurse that her infant is in a breech presentation. This presentation is associated with an increased risk for childhood handicap. Therefore, this baby will likely be delivered via C-section. The client may wish to undergo an external-cephalic version in an attempt to manually reposition the baby into a vertex presentation. A number of interventions may be implemented to support this procedure and increase the likelihood of success. Studies have shown which intervention to be the most successful. The intervention will be the use of tocolysis. And so that is the end of this lecture. It was quite a long lecture.